Good afternoon, everybody. I'm Olfa Hamzawi. I'm intensivist in intensive care Antoine Béclair Hospital from Paris-Saclay University Hospitals and a member of the cardiovascular session in ESICM. I'm very pleased to chair this webinar from the ESICM supported by GE Healthcare around fluid responsiveness. And as you know, in critically ill patients, the decisions to give fluids is a big issue at the bedside for all the physicians who try every day to find the good balance between, in one hand, not inducing fluid overload, and the other hand, not missing hypoperfusion due to a real need of fluids. The decision to give or not fluids should not be taken lightly, and I'm sure that after this webinar, you will have the right keys for this daily deal. In this webinar, we will have the opportunity with our international experts to discuss, firstly, how to differentiate between the need of fluids and fluid responsiveness, and secondly, the appropriate use of non-invasive method to assess fluid responsiveness. So you can send your questions directly on the ESICM TV or via ESIGM Facebook and YouTube account, and we will have time to answer them after the two talks of our experts. So first, I have the great pleasure and a big honor to introduce one among the most recognized experts in this field, Professor Xavier Monet. Professor Xavier Monet is Professor of Intensive Care in the Medical Intensive Care of Bicêtre Hospital from Paris-Saclay University Hospitals in France. He is also the chair of the cardiovascular session of the ESICM, and he will talk about the need of fluids versus fluid responsiveness. So please, Xavier.
Thank you very much, Alpha, for your very nice and kind introduction. And before starting, I disclose my collaboration with Pulsion Medical Systems Göttingen and with Baxter. You're right, it's not a light question, but what are we speaking about exactly? Let's think about a patient, for instance, with septic shock on community-acquired pneumonia on day one. In this patient, the PF ratio is low, the blood pressure is low, the PEEP is elevated, and the patient has already received 1.5 liters saline and is under norepinephrine. Blood pressure is still low. Should we give fluid to this patient or not? This is, you will agree, the daily question. The first issue we have with this treatment is that all the patients do not respond to fluid administration through the expected increase in cardiac output. Initially, this was totally ignored, but when colleagues started to measure cardiac output at that time with the pulmonary artery catheter in the 80s, they observed that some patients had no increase in stroke volume. This is the first study, I think, showing that after fluid administration. And after this first study of Calvin and co-workers, many of them and many since this first study reviewed here 20 years ago, many studies confirmed that half of the patients only response to fluid administration through a significant increase in cardiac output, and likely you know that. And the main reason is basically physiology. As if we give fluid administration, actually we expect that stroke volume and cardiac output increase. In this way, we use the cardiac output relationship, the Frank-Starling curve at the bedside. But basically, you know, from your first years in at medical school that the slope of the Frank-Starling curve basically depends on the ventricular function. And this explains why the same fluid administration with the same volume of fluid may lead to a significant or a negligible increase in cardiac output. It means that fluids are not fluid responsiveness. These are totally different concepts. It's not because you give fluid that your patient will respond to fluid. That's really an important issue. For years, it was not that sure, but today we know all the drawbacks, all the adverse effects of fluid administration in our ICU patients, and likely in the operating room patients as well. The effects of fluid are not constant, and even more when you give fluid, and that it does not increase cardiac output, it has only adverse effects. Mainly, it increases lung water, it increases lung edema, it promotes intra-abdominal hypertension, it reduces hemodilution, it promotes also right ventricular failure, etc. And more than theory, we know that's been clearly demonstrated today. Just to show you one study, the first that's been clearly showing that in septic patients, the sub-analysis of the SOAP study, definitely the total amount of fluid administered, the cumulative fluid balance, is an independent predictor of mortality in these patients. The more fluid you give to these patients, the more they die. And so we are left with these two issues in constant effect and potential harmfulness, which means, by the way, and confirms, by the way, that fluids are drug. We should logically predict fluid responsiveness before giving fluids. Just as antibiotics, fluids are drugs with several adverse effects and an inconstant efficacy. If you try to predict before giving antibiotics whether they will be effective or not on the germ you want to treat, the same, you should test fluid responsiveness before giving fluid to your patient. In fact, in our mind, we are drawing this very simple algorithm. Is cardiac output too low? Urine output is low, lactate is elevated. Should I give fluid? There are two cases. In the minority of cases, you know that the patient will be fluid responsive because fluid losses are obvious, because it's the very early phase of septic shock with obvious relative hypovolemia. In these cases, definitely you should not try to predict fluid responsiveness, because it is very likely in these cases you should give fluid, and that's all. But in the majority of cases, in all the other cases, you know that only half of the patients will respond positively to fluid administration. It means you should look at indices that will tell you before starting fluid infusion that the patient will very likely be fluid responsive. And as you know, for this purpose, static markers of cardiac preload as central venous pressure, for instance, are not valuable at all, and we should look for dynamic indices. What are we speaking about? This concept of dynamic prediction of fluid responsiveness is in fact very, very easy. It's a way to assess the slope of the cardiac function curve at the bedside. I mean, you change preload, or you observe spontaneous changes in preload, for instance, fluid administration, effects of ventilation, etc., and you look at the changes in cardiac output, stroke volume, or surrogates. If the change is significant, then you can give fluid, being sure that the patient will respond to fluid positively. Otherwise, you refrain from fluid administration. And during the last 20 years, several indices were developed to predict fluid responsiveness in a dynamic way. And I suggest that together in the next minutes, we review all these indices, methods, and that we together consider their advantages and drawbacks. Definitely the easiest way to assess fluid responsiveness is just to give fluid and look at the response. It means a fluid challenge. Give 300 or 500 milliliters to your patient and see how he or she responds. It's very easy to do. Two main drawbacks. The first one is that bear in mind that to correctly assess the response of fluid during a fluid challenge, you must measure cardiac output. If you look just at pulse pressure, arterial pressure, it is not reliable enough. You need to directly measure cardiac output. But even more importantly, inherently fluid challenges that perhaps many of you like a lot induces fluid overload. This is inherent to the method you use. Why? Because it is not a challenge, it's the treatment itself. I mean that you give fluid to a patient, and if the patient does not respond, you go on with the next bolus, etc., until the last bolus that does not increase cardiac output and stroke volume anymore, and then you stop fluid administration. This is basically the fluid challenge. Let's imagine a patient as the one we spoke about at the beginning. Septic shock with ARDS on first day. You will agree with me, your patient will experience perhaps 5-6 episodes of hypertension, which means that obviously this induces fluid overload. You cannot remove the fluids you've given to your patient, and definitely the fluid challenge is not a challenge, it's the treatment itself. This is why the concept of giving small amounts of fluid, 100, 150 milliliters, a mini fluid challenge might be interesting, and we now have some positive studies. My point regarding mini fluid challenge is that it requires a precise measurement of cardiac output. What do I mean? This is the first study of some French cardiacs showing the interest of this mini fluid challenge. 1 milliliter of starch in this patients could discriminate responders from non-responders. Nevertheless, small amounts of fluid can only induce small changes in cardiac preload that can only induce small changes in cardiac output. And in this study, these small changes were detected by echocardiography. We will speak about that likely later with Dr. Sanfilippo, but is cardiac echo reliable enough, precise enough to detect so small changes in cardiac output? Likely not. I'm even sure that it's not the case. Because the smallest change that you may trust with echocardiography in the velocity time integral in this estimation of stroke volume is 10% only. Smaller changes, you're not sure that it will be detectable with accuracy. That's why for this mini fluid challenge, I would much better rely on some more precise techniques for measuring cardiac output, cardiac index, as for instance, pulse contour analysis or other continuous methods. And for instance, in this study by the team of Mathieu Vier in Bordeaux, they showed that pulse contour analysis detected the mini fluid challenge effects. Look at the change in stroke volume less than 10%, 6%, which is compatible with the precision of pulse contour analysis, not of echocardiography. Anyway, it still requires to give fluid to the patient that you cannot remove. As all of you know, pulse pressure, stroke volume variations that have been developed 20 years ago are very reliable indices of fluid responsiveness. But on the other side, we can use them in a minority of patients. And the main circumstances, situations where we cannot use these indices because they are not valuable anymore are cardiac arrhythmias, spontaneous breathing, even in an intubated patient, spontaneous ventilation, and ARDS because of lung compliance, low lung compliance, and low tidal volume. And the problem is that it's likely a large proportion of our ICU patients where we cannot use PPV and SVV. Nevertheless, we can say that there might be a solution in the specific case of ARDS with the low tidal volume, which is that tidal volume challenge that's been developed 4 years ago by Dr. Mayatra and some other Indian colleagues. And the principle is very simple. No need to measure cardiac output. You just increase the tidal volume from, for instance, 6 to 8 milliliters per kilogram, and look at the induced changes in pulse pressure variation. And if if pulse pressure variation increases by more than a given threshold, it's very likely your patient is fluid responsive. In this first study, we showed that the threshold was a 3.5% increase in ppv. Nevertheless, some other studies found smaller thresholds, as the one we just published in Critical Care, where we show that the threshold was a 1% increase only. So I think that further studies should try to refine the threshold of the tidal volume change. The changes in the diameter of inferior IVC, superior SVC, vena cava are very popular indices. I think that many colleagues like it a lot. Actually, you don't need to measure cardiac output or VTI or stroke volume. Just look at the changes in the diameter of the vena cava. First drawback, you must know how to do that. Nevertheless, it's very easy to assess it. At least the IVC. SVC is much more complicated. You need TEE. It's not easy. But IVC, definitely, it is very easy. My point here is that keep in mind that these are the less reliable indices of fluid responsiveness we have. It's today very clear. Many small-size studies showed that, and many meta-analyses of this study confirmed that. Even more, we have a 2017 large French negative study. Look, in that study, the ability of the changes in the IVC to detect preload responsiveness was very low. The area under the RAC curve was only 0.65, which is very low. So it is well demonstrated, and likely it can be explained why. Why does, for instance, the IVC change with ventilation in fluid responsive or preload responsive patients? Did you think about that already? It's not only due to the slope of the Frank-Starling curve. I mean that if it changes, it's likely because, yes, the intramural pressure, the CVP, changes in case of preload responsiveness. But the change also depends on other factors. The compliance of the IVC, the intra-abdominal pressure, and so the transmission, the degree of transmission between the thoracic and the abdominal pressure. It's not only related to preload responsiveness. And I think it is the reason why it has a so low predictive ability. In addition, these changes in vena cava diameter share most of the limitations of PPV and SVV. Do not use it in patients with low tidal volume and spontaneous breathing. And expiratory occlusion test perhaps you've heard about that test that we developed years ago with Jean-Louis Teboul in this study. The principle is very easy. It's all about heart-lung interactions. Indeed, in a patient with mechanical ventilation, you agree that each insufflation tends to impede venous return. It decreases cardiac preload, and then the next cycle stops. The cycle stops, preload increases. Next insufflation, preload decreases, etc., etc. And so the principle of the test is that if you stop mechanical ventilation for a few seconds, for instance, 15 seconds, you increase cardiac preload for a few seconds. And if in turn stroke volume increases, it means that both ventricles are preload dependent. The duration must be at least 15 seconds or 12 seconds because the preload bolus must cross the pulmonary circulation, and also the cardiac output monitors we use must average this change in cardiac output. And today we have several studies showing that there is a good level of reliability. We performed this meta-analysis a few months ago with Francesco Gavelli. You see the threshold is a 5% increase, and look at the area under the RUC curve, 0.95 compared to IVC changes. It's totally different. It's very easy if you have a direct display of cardiac output under your eyes, for instance, with pulse contour analysis again, or any other technique. With echocardiography, it is possible, but since the threshold is low, and because of the precision of echocardiography, we showed in this study that you need to add to the end expiratory occlusion an inspiratory occlusion that will enlarge the induced changes with a higher threshold, but that will make the changes in cardiac output induced by the test detectable by echocardiography. Of course, it's not possible to use it in patients with a strong respiratory efforts. They interrupt the occlusion. And again, you need something that measures cardiac output. It's difficult to measure with blood pressure only. Let's end up with the passive leg raising test that likely you know. Many studies have shown that it is a reversible preload challenge. On average, the volume is 300 milliliters of blood, but it's very variable from one patient to another. But it's a pseudo fluid challenge. I would like to insist on 2 last points regarding the passive leg raising test. The first is that you need something that measures cardiac output to perform the test. Unfortunately, if you use arterial pressure, and especially arterial pulse pressure, it's not very reliable. Then you need something that measures cardiac output. And many studies have looked at reliable ways to perform the test in a non-invasive way, because of course you can use pulse contour analysis, but of course all the patients are not equipped with such systems. Esophageal Doppler, not easy in the ICU. Echocardiography, you look for an increase in the VTI by more than 10%. Capnography, I don't have time to show that, but it's interesting. Bioreactance is reliable. Changes in carotid flow, I think it is not reliable, but again, no time to insist on that, because I'd like to speak about plethysmography. SpO2 to assess the effects of passive leg raising. This PLET signal that we have under our eyes every day, in fact, is made of 2 parts. There is a pulsatile systolic part of the signal and a non-pulsatile portion that you don't see on your screen. And the ratio between both is called the PI, the perfusion index. And you can easily understand that it has 2 determinants. The first one is vasomotor tone. Of course, if the patient is vasoconstricted, the PI is low. But also stroke volume, because it will increase the pulsatility of SpO2. So is it possible to use that amplitude of SpO2 to assess the effects of, for instance, passive leg raising or a fluid challenge? I don't show all the details of this study that we performed, but look, the changes in this PI were able to detect the changes in cardiac output induced by passive leg raising and volume expansion. And for instance, in this fluid non-responder here, there was no change, neither in cardiac index nor in perfusion index. So SpO2 to detect changes in cardiac output during passive leg raising. Be careful, we had to exclude some patients because the signal was very unstable. We showed recently that the PI can also detect the changes in the end expiratory occlusion test. We need some confirmation, but likely a way which is costless, non-invasive, and widely available to assess changes in cardiac output in these tests. Finally, you may use just PPV, which is displayed on your screens, for instance, during passive leg raising, as we showed recently. Finally, less reliable in case of intra-abdominal hypertension. Likely, there is less volume in the abdomen, less possibility to less volume to mobilize during the test. It's been suspected for years that it may induce some false negatives, and we confirmed it in this study published 2 years ago. In patients with intra-abdominal hypertension, fluid increase, volume expansion, increased cardiac index, passive leg raising to a lesser extent, meaning that there might be some, not all, but some false negatives in these cases. So I think the best dynamic ways to assess fluid responsiveness might be the mini fluid challenge, the end expiratory occlusion test, and passive leg raising. Thank you very much for your kind attention.
Thank you, Xavier, for your, as usual, your brilliant presentation. And I'm sure that we will have a lot of questions after, and we'll try to have some time for the question. And now let us move to the second speaker, who is one of among our brilliant experts in echocardiography, and he's part of the ASIG group for advanced echo accreditation, the EDEC program. Dr. Filippo Sanfilippo is a consultant in anesthesia and intensive care at the Policlinico University Hospital in Catania. And he will be talking about non-invasive assessment of fluid responsiveness. So please, Filippo.
Thank you very much, also for the introduction. Thank you for the invitation. It's such a privilege. I hope this is running the presentation. Sorry, we have.
Need to share? Yeah.
Yes, it's probably
okay.
sharing now. And I apologize. Okay, is that okay now?
Yeah, it's okay.
Sorry. Okay, thank you very much again for the invitation and the presentation. It's an honor and privilege. I have no conflict of interest. And in the agenda, what I did put is a couple of thoughts on what is non-invasive in the intensive care, and then, of course, we'll talk about echocardiography, point of care under ultrasound, and a few other considerations on non-invasive assessment for fluid responsiveness. When I was given the title, the first thought was, okay, I'm going to speak about ultrasound for sure, but before that, I thought, what is truly non-invasive in the intensive care? And certainly, most of our patients have got an arterial line catheter in situ. So, in this case, monitoring advanced cardiac output with pulse control method analysis or other approaches. It doesn't mean adding any invasive or risk to harm to the patient. So, echo is not mutually exclusive with this other monitoring tool. And before moving to the approaches to define fluid responsiveness with non-invasive methods, I would like to remind about the Fenice study led by our president, Maurizio Cecconi, which showed that most of the fluid challenges were given without a variable used. And when a variable was used, people used mainly static variables, while dynamic variables were used only in 22% of the all fluid challenges. And if we look in green at the bottom of the screen, the echo variables, these were used very rarely. Echocardiography and point-of-care ultrasound variable are based mainly on dynamic evaluation and rather than on static measurement. And during this presentation, we'll try to cover assessment of fluid responsiveness using the heart, the veins, and the arteries. So from the heart perspective, as mentioned already by Professor Monet, we evaluate the variation of stroke volume and cardiac output and how these changes over time with either preload redistributing maneuvers as passive leg raising or with ventilation-induced changes. The calculation of stroke volume and cardiac output, I'm sure most of the people are aware, is performed with echocardiography, calculating the diameter of the LVOT and then to get the pulse wave Doppler analysis of the flow in the LVOT with an apical 5-chamber view. Professor Monet has already discussed the limitation of echocardiography measurement in cardiac output with inter and intra-observer variability, of course. And in this regard, some help may be given, but needs research and study. But this new software that allows automated tracing of the VTI, as you can see in this example, where the LVOT diameter was 2.2 centimeter, and the machine already calculated the VTI and gave us number of stroke volume and cardiac output. Of course, it can be calculated also with chances of IGL echocardiography. The principle behind are the same, just the views are different. I'll move now to the bigger part of the presentation, which is the use of the venous district to assess fluid responsiveness. And certainly the inferior vena cava is the most studied parameter, where in order to understand the fluid responsiveness, we evaluate changes in the diameter of the vena cava, and this is performed according to the change in the pressure into the chest during either spontaneous or invasive mechanical ventilation. Now, the pioneer were our French friends, and in particular, in 2004, we have two important papers by the group of Professor Jean-Louis Teboul and the group of Professor Antoine de la Baronne, where the authors found a different cutoff for fluid responsiveness, but please note how they used the different formula. While the group of Prof. Teboul did divide the variation of the IVC diameter over the IVC mean diameter and found a 12% cutoff to predict fluid responsiveness, the group of Professor Antoine de la Baronne divided the variation of the IVC by the IVC minimum diameter, and that they found that 18% cutoff. The last formula is probably the one that is more commonly used, and is called the IVC distensibility index. This is important from dictionary perspective, because the term refers to the increase in size during the inspiration. We have also studies that were performed later on by other groups, and in the patient with spontaneous ventilation. In this case, all the groups have used the IVC collapsibility index, where the variation of the IVC diameter is divided by the IVC maximum diameter. And the authors of these studies found that good cutoff for fluid responsiveness are around 40 to 48%. However, as already mentioned by Prof. Monet, the group of Professor Philippe Vignon from France performed a much bigger studies than the other one, where they found lower sensitivity and specificity. And in this regard, then I think it's fair to show you the pooled results from meta-analysis and what we can take from the IVC. So there are several meta-analyses, and one of these in 2017 started to introduce the concept that fluid responsiveness using the IVC variation can be better predicted if we use it in mechanically ventilated patients, as you can see, where the area under the curve decreases slightly in the patient not ventilated. But what I find very interesting is this other meta-analysis in that published in Anesthesia and Analgesia on November 18 by the group of Shaanxi, where the authors identified 12 big studies in evaluating the IVC variation for fluid responsiveness. And they identified that ventilator settings were a source of significant heterogeneity. And therefore, the authors decided to divide studies according to the way patients were ventilated. Therefore, we have 6 studies where patients were ventilated with at least 8 ml per kg of tidal volume and with a PEEP of 5 centimeters of water or below, while the other 6 studies were performed in patients with lower tidal volume and or higher PEEP level. What the authors found that the area under the curve was much bigger and reliable when the patients were ventilated with bigger tidal volume and lower PEEP, rather than when patients were ventilated with low tidal volume and higher PEEP. So this is a take-home message. Recently, it's in 2021, the group of Alvarado Sanchez published a meta-analysis looking at predictors of fluid responsiveness in patient ventilated at low tidal volume. And if we look the results of the IBC, we can see that the area under the curve is 0.86, which is a bit lower than others, but not so lower. As mentioned by Prof. Monet, there are a lot of situations where the IBC cannot be reliable, and this is a nice review by Gabriele Via, and among others, I would like to mention the RB failure, tricuspid regurgitation, cardiac tamponade, and as mentioned by Prof. Monet, also intra-abdominal hypertension. There are several reasons when and conditions and scenario where the IBC is not reliable. I would like to continue a bit on the IBC with a couple of news. First of all, the use of artificial intelligence, which seems promising in this study. The algorithm of artificial intelligence was in good argument with the point of care ultrasound expert for evaluating the IBC collapsibility. And the use of, as you can see in these images, of software for automatic border detection of the IBC can be helpful also in decreasing the time of data collection at the bed space and allowing repeated measurement. The other concept that I would like to introduce on the IBC is the possibility to use another window to look at the IBC. As you can see here, it can be imaged through the liver, basically using the transhepatic view. The first study was conducted by our Indian colleagues, and the authors found that while the diameters were not reliable comparing the standard and the transhepatic view, the limits of argument were acceptable when they looked at the percentage variation. So this could be an option when you have patients with chest drain, like in this study by the group of Massimiliano Maineri, where they performed the same concept study in the postoperative period of cardiac surgery, but also when we have patients with laparotomy or with difficult views for looking at the IBC from the subcostal approach. So again, of course, the automated border detection can be helpful, and this is an example where collapsibility index was 26% in the subcostal and 23% in the transhepatic view. Let's move now to the superior vena cava, where, of course, as mentioned by Prof. Monet, is performed in mechanically ventilated patients. It requires much more skills and the use of transesophageal echocardiography, which is not everywhere available. The pioneer group in this regard is the group of Professor Antoine Villard-Baron, where they calculated the SVC collapsibility index because of the collapse of the SVC during inspiration. And the authors found that 36% cutoff predicted with 100% accuracy the patient with an increase in cardiac index after volume expansion, with a 90% specificity in patients that didn't respond to volume expansion. How does the superior vena cava perform as compared to the IBC? It seemed to perform better according to this study, where the authors found that a cutoff of 35%, which is very similar to the 36% identified by the group of Prof. Villard-Baron, and much better specificity and sensitivity as compared to the IBC distensibility index. Another option is to use the miniaturized TEE probe, which is available in some units. And in this study, in patients undergoing open major vascular surgery, the authors compared the SVC collapsibility index with stroke volume variation. And what they found is that both indexes had a good predictivity, around 0.9%, and again, that cutoff was very similar to the one used by the group of Professor Villar-Baron. One concept that must be clear is, of course, that with the HD there is no omniplane, and the SVC is identified in short axis view, while in transesophageal echocardiography we use it in long axis view. Let's move now to other part of the venous district, which I called as non-vena cava vein. And several districts have been evaluated for fluid responsiveness: subclavian, internal jugular, femoral, and hepatic. There are these two studies by Dr. Kent, which I will summarize in this table to make it easier. So in the first study, the authors evaluated the IVC as compared to the subclavian vein with 94 paired measurement. And in the second one, they evaluated the internal jugular vein or the femoral vein as compared to the IVC. What the authors found is that time to data acquisition is shorter for the three other districts as compared to the IVC. However, the subclavian vein and the internal jugular vein had an overestimation of 3.2 to 3.5%, while the femoral vein had a 3.8% underestimation. More importantly, the correlation was acceptable for the subclavian vein, but wasn't that good for the IJV or the femoral vein. Also, hepatic vein, and in particular the middle hepatic vein, have been studied. In this regard, it's a bit more complex, the analysis of pulse wave Doppler, but one of the most important parameter in this pattern is the change in the diastolic flow, and this is a study from our Chinese colleague that found a very good area under the curve by the changes in the D wave calculated with echocardiography. So, sorry, with point of care ultrasound, of course. My summary on the use of non-vena cava vein for fluid responsiveness is that they are interesting. They are targets that most of the time are accessible and easier to perform, but people must be aware of the measurement bias, the different cutoff for each index, and the correlation anyway is never really strong with the IVC. And more importantly, we know that there are factors interfering with the IVC and the SVC diameter and their changes, and there is no reason to why this shouldn't affect also the flow upstream. Let's move now to the arteries. And regarding the arteries, the ascending aorta has been used mainly in children with echocardiography, but the carotid artery is another interesting target that I will discuss. One of the most common indexes that have been studied is the corrected carotid flow time, where the operator evaluates the time between the systolic peak to the dicarotid notch, and as a rule of thumb, the lower the time, the most likely the patient will be fluid responder. Of course, this needs to be corrected for the heart rate, and this is why we call it corrected carotid flow time. Another one is the carotid blood flow, which essentially has the same principle behind the calculation of cardiac output. So we measure the diameter of the artery and the VTI with pulse wave analysis. There are several studies on the corrected carotid flow time, and I will show you this one from the group of Maxime Canson, where patients with undifferentiated shock had a good area under the curve when the corrected carotid flow time variation after passive leg raising was used to identify fluid responders. However, there are also studies that were not able to identify a cutoff point on the use of carotid flow time. My summary on carotid flow time is that certainly the easy identification of the artery is a good point, but the analysis can be challenging because it needs some angle correction, because the measurement is in milliseconds, and therefore it's more prone to measurement errors. And the identification of the dichrotic notch may be more challenging, especially in very tachycardic patients. There are conflicting findings between studies. And the last point is that carotid blood flow could be a better alternative, at least as shown by the group of IRIN-MA, where measurement of carotid blood flow was a better marker of fluid responsiveness and as compared to the carotid corrected flow time. There are several other non-invasive assessment of fluid responsiveness with non-ultrasound and non-arterial line methods. Prof. Monet has shown you about the saturation waveform analysis, but again, Prof. Monet has conducted several studies also on end-tidal CO2 variation after passive leg raising for fluid responsiveness. Before concluding my presentation, I would like to stress that fluid may be harmful to the patient, and therefore we need to collect as many information as possible or as feasible. And the risk to harm the patient comes not only during information acquisition, so when we use invasive versus non-invasive methods, but also when we collect information that may be not accurate or precise, and therefore we could make wrong clinical decisions. The non-invasive tool for fluid responsiveness can be associated also to other non-invasive tool to evaluate whether the patient needs fluid, and certainly in these regards the use of lung ultrasound or the venous congestion score by Philippe Rolla could be really promising tool that are under investigation. In conclusion, there is certainly no holy grail for non-invasive assessment of fluid responsiveness. And echocardiography and point-of-care ultrasound are invaluable too, but not only for fluid responsiveness, for the assessment of patients in shock, and so on. There are issues on training and resources, of course, as well. And clinicians should combine all the information to decide whether fluid administration is appropriate. And finally, let me mention that there is no reason why in the future intensivists shouldn't be competent in echocardiography and point-of-care ultrasound. So please do consider the European Diploma of Echocardiography by our society, and also to join our annual Congress that will start in less than 1 month. Thank you very much for your attention.
Thank you, Dr. Filippo Sanfilippo, for this nice and complete presentation about the non-invasive devices for assessing fluid responsiveness. And we have just 10 minutes for question. I have some question for the moment for Xavier, but probably we should have some other question for you, Filippo. So the first question is that can we use the PPV and SVV in the following situation? The first situation, when patient has intercostal tube, chest tube, or abdominal drains, because there is probable disruption of the pressure transmission. And the second part for the situation is can we use these parameters when we have long femoral access for RRT?
So thank you for the question. Chest tubes and abdominal drainage. Abdominal drainage, it's not, I think it's not been investigated. Olfa, do you know any study about it? Abdominal drainage, I don't know.
No.
Chest tubes, likely it is less reliable because, of course, some of the pressure induced by ventilation is escapes out of the lungs. Less reliable and false negatives. Regarding renal replacement therapy and femoral artery, PPV and SVV keeps its reliability. And it's not, I mean that, of course, it may detect hypovolemia induced by priming of the circuit, by ultrafiltration by the circuit, etc. But of course, the arterial line must not be in contact just with the there must not be a, how may I say? Of course, it should not be in a fistula. Okay, of course, if renal replacement therapy is performed in a vein and PPV is measured in an artery.
Artery.
That's what
recirculation of. Okay, Xavier, the second question is regarding the end expiratory occlusion test. How practicable to induce breath hold for 12 seconds in ICU? I think you have a quick answer for this.
Exactly as you do for measuring the intrinsic PEEP, you know. You have a button on the ventilator, you click on it, and you wait until 15 seconds. In some ventilators, by the way, it stops automatically at 15 seconds for avoiding too long ventilatory pauses. So just by click on the button and look at the patient. If there is no breathe, spontaneous breathe, if the patient is totally awake, for instance, then the test is valid. And at the same time, you look at the value of cardiac output, or with echocardiography at VTI or SpO2, etc., etc. So it is just by clicking on the button. Again, the time is a bit long. I repeat, the cross of the pulmonary circulation and the fact that you have to average several values of cardiac output. So to keep the max value, to catch the max value, you need to have a quite long end expiratory occlusion. But 5 seconds, definitely it's too short. You will see nothing on cardiac output.
And Xavier, as you said, also if the patient has a lot of inspiratory effort, spontaneous inspiration, it's not possible to do that. But it's not very frequent in your practice.
It's not that frequent because in the ICU, many patients have a low-level sedations or spontaneously do not breathe that much. But it's true that in some patients, it is not possible. The study we performed, we found that I think it was in 10 or 15% of common ICU patients that definitely it's not possible. So it's not a majority of the patients, it's a minority of them.
Okay, I still with you, Xavier, and I will read integrally the question. Hi, Xavier. In 2016, you published a study, My Patient Received Fluids, in which you underline the side effects of fluid administration. In view of this, should we redefine the term of fluid responder, not only for cardiac output increase, but also tissue oxygenation without increasing CVP or intra-abdominal pressure, extravascular lung water, no hemodilution, no RV impairment? A new definition?
I thank our friend for that long question. Our point in this review is to say that it's not just give fluid and go away. No, you should really look at the response to fluids. Of course, you measured preload responsiveness, you assessed preload responsiveness before, but after fluid infusion, do not leave the room. Did cardiac output actually increase? Did tissue oxygenation increase and improved? And it's not in all the patients with increase in cardiac output. Did you induce some adverse effects of fluid administration, increase in CVP, in lung water, etc.? So it is not just assessing preload responsiveness, but also the response, positive and negative response to fluid administration.
Okay, thank you, Xavier. A last question for you, Xavier, and then after for Filippo. Is PPV and SVV useful in patients with heart rate more than 140 beats per minute?
Likely not. There have been one study, at least one I know, by the team of Daniel Debacker, showing that if heart rate is too high, PPV has no time to vary, in fact. But of course, for this, you really need a very rapid I'm sorry. It is with rapid ventilation. So if the rate of ventilation of a heart rate is very high, then you cannot use it. I think it's only for exceptional values actually, but it may happen. Okay, it happens for respiratory rates more than 40 breaths per minute. Regarding heart rate itself, so tachycardia, there is no reason because it works even for high heart rates, even more because ventilation, if ventilation is slow enough, you will see variations, whatever the number of cardiac cycles. So tachycardia, no problem. Very rapid ventilation. It might be a problem with false negatives in case of very, very rapid ventilation.
Of course. And when it is tachyarrhythmia, of course, it's not applicable and it's not valid.
Very good point. You're right, of course, to mention that.
Yeah. So, Filippo, we have some question for you. I will read it also in Tugri because it's a nice question. Thank you so much for that brilliant presentation. I would like to know if I can use VTI variation and the mechanical ventilation to assess fluid responsiveness.
Okay, thank you for the question. Yes, I mean VTI variation are calculated with a pulse wave Doppler and can be used. And I would suggest to couple it with maneuvers that change the load to the patient. Let's say passive leg raising. Of course, also with the variation in the ventilation. Okay, so you measure the biggest and the smallest VTI, but as you phrase it, there is a risk of also errors, and as mentioned by Prof. Monet, there is a high variability, inter-observer and intra-observer variability. So then when you measure it and you have a big variation, then it will be clear that your patient is possibly fluid responder. But for smaller variation, then on its own could be less effective. I would suggest to couple it with the passive leg raising, with variation, or with an expiratory occlusion test, and so on. The technical issue is that you need to stay still with your probe, and you need advanced skills from echocardiography perspective, and so on. And we know also how can be challenging to gather apical 5-chamber view in patient ventilated in the intensive care. So also the feasibility of it, it's an option. It's an issue that can be taken on board.
Okay, so
sorry, can I make a comment very briefly on the first question received by Prof. Monet? Agree that there are no studies on the chest tube and how they influence the IVC variation or other indexes. But if the chest tube is there not for a big pneumothorax and with a risk of accumulation, the chest tube can be clamped for a few seconds during the assessment. So this is an option that can be considered settled if it doesn't expose the patient to risk.
Okay, so what about the IVC diameter usage in femoral venous excess for CRRT?
What about the the IVC and in the venous excess tool? I mean, we are still in the pioneer era for the venous excess ultrasound, and I would first consider if the patient is fluid responder, and then if the operator is skilled to use DEXUS or lung ultrasound, then of course take this information on board. If you use it during a CRRT, I'm not aware there are studies evaluating. We still need studies on DEXUS, and then of course on the limitation of DEXUS, let's say like patient undergoing CRRT. So I'm not aware of any study in this regard, and it may influence, of course, but needs to be properly studied and addressed from scientific perspective.
To continue with the VEXUS, I have a question. What is your cutoff point of fluid therapy?
I personally must admit that I don't use VEXUS frequently. is still something that needs to be studied. And I think we still need evidence before we introduce in clinical practice. We don't need to be over enthusiastic with ECHO as with any other tool. We just need to evaluate scientifically all this and see whether they can help to distinguish patients that may need or may not need fluid. I think Dexus will have lots of space during the recovery of the patient, the critically ill patient, when we will use it to understand how much intravenous congestion and how much we need to push on fluid removal. And there are studies by Manu Malbrain and other experts implementing also CRRT during recovery of the patient for speeding up the fluid removal. But we are still at early stages.
Okay. Xavier, we have a last question and then we finish. Increasing cardiac output doesn't assure increasing blood pressure. Do you think you could be satisfied with only increasing cardiac output?
It depends for which test. If we speak about fluid challenge or passive leg raising, which is like a fluid challenge, then it must increase cardiac output. Basically, fluid should increase cardiac output, and blood pressure is only a side effect, and it does not always in all the cases. So basically, that's why for this test, you need to measure cardiac output or estimate it in a way, but you can, unfortunately, you cannot rely just on blood pressure. So definitely what you must look for, fluid, test of fluid responsiveness. Basically, it is for an increase in cardiac output or a surrogate.
Okay. Thank you, Xavier. Thank you, Filippo. We thank all the audience and ESICMG Healthcare for this nice webinar. And I say to you just good evening, everybody.
And thank you, Alpha. Thank you very much for your moderation.
Bye-bye. Bye-bye.